Hi, I am going to talk about Lumacaftor and Ivacaftor in patients with cystic fibrosis homozygous for Phe508del CFTR. Cystic fibrosis is a genetic disease that is associated with high rates of premature death. It is a multisystem disease that is characterized by pancreatic insufficiency and chronic airway infections associated with loss of lung function, repeated pulmonary exacerbations, and ultimately respiratory failure.
It alters the body's respiratory, digestive, and reproductive systems. It affects the body's epithelial cells that comprise the lining of the lungs, pancreas, liver, sweat glands, digestive tract, and reproductive system. Normally, the epithelial cells release a slippery layer of mucus, captures dust and germs, and acts as a lubricant. A person with cystic fibrosis inherited a gene that causes the epithelial cells to produce a defective protein. That protein leads to the formation of thick, sticky mucus, which causes many serious problems. The sticky mucus can clog the bronchial tubes, interfere with breathing, causing coughing and wheezing, cause fatigue, interfere with digestion and absorption of nutrients, which can limit growth and weight gain and cause chronic diarrhea. Common symptoms of cystic fibrosis include persistent coughing, poor weight gain, bulky stools, and very salty tasting skin in infants. Treatment of cystic fibrosis varies according to the stage of the disease and which organs are affected.
Cystic fibrosis is caused by gene mutations that result in deficient or dysfunctional cystic fibrosis transmembrane conductance regulator (CFTR) protein, an ion channel that is normally present in the epithelial membrane. Phe508del is the most common CFTR mutation. Approximately 45% of patients with cystic fibrosis are homozygous for this allele. Cystic fibrosis is a progressive disease, despite advances in therapies designed to address the symptoms of the disease. The median predicted survival among patients who are homozygous for Phe508del in the United States is 37 years old. The Phe508del CFTR mutation causes a processing defect that severely reduces protein levels at the epithelial membrane for the few channels that reach the cell surface. The mutation also disrupts channel opening together. This effect leads to minimal CFTR chloride transport activity. Treating cystic fibrosis. One approach to treating cystic fibrosis is to address the underlying cause of the disease by targeting the CFTR protein dysfunction. Restoring chloride transport to Phe508del CFTR is therefore thought to require at least two steps: correction of cellular misprocessing to increase the amount of functional emulated CFTR and potentiation to further increase channel opening. Lumacaftor, Ivacaftor. Lumacaftor is an investigational CFTR corrector that has been shown in vitro to correct Phe508del CFTR misprocessing and increase the amount of cell surface localized protein. Ivacaftor is an approved CFTR potentiator that increases the open probability of CFTR channels. in vitro and improved clinical outcomes in patients 6 years of age or older who have cystic fibrosis and at least one copy of the MOS class 3 mutation. Lumacaftor Ivacaftor advantages. In vitro studies have shown that Ivacaftor also potentiates surface localized Phe508del CFTR, and the combination of Lumacaftor with Ivacaftor has been associated with a greater increase in chloride transport that has either aging alone.
Hi, my name is Felix, and I have cystic fibrosis.
Hi, my name is Fiona, and I have cystic fibrosis.
Hi, Charlie!
What is cystic fibrosis?
Cystic fibrosis, or CF, is a genetic disease. That means we're born with it. When we are born, our genes determine our eye color, hair color, and if we look like mom or dad.
A defective gene causes our bodies to create a really thick mucus that covers our internal organs, especially our lungs, making it hard for them to work correctly.
Is it only you two who have CF?
No, there are 30,000 people across the country and 70,000 worldwide who have CF.
What happens to you when you have cystic fibrosis?
Because the mucus is covering our lungs, it makes it hard for us to breathe. We can do everything you can do, it just takes us so much more energy.
Can you give your CF to someone else?
No, cystic fibrosis is not contagious. You either have it when you're born or you don't.
You don't look like you have a disease.
On the outside, we look like all of you. But on the inside, our organs are working overtime. All the time, just to function properly.
How else is your body different because you have cystic fibrosis?
Well, we have to be very careful not to get sick. When you get sick, you might be in bed for a few days. When we get sick, we can end up in the hospital.
The mucus inside our bodies holds on to the germs and bacteria, making it very hard to get better. Sometimes we can be in the hospital for months.
Is there something you can do to stay healthy?
We try to keep our lungs as clear of the mucus as possible.
Although neither Ivacaftor or Lumacaftor monotherapy have been shown to have meaningful clinical efficacy in patients who are homozygous for the Phe508del CFTR mutation. A phase 2 study suggested that the combination of Lumacaftor and Ivacaftor increased CFTR activity to a degree that may be sufficient to improve clinical outcomes in these patients. Lumacaftor-Ivacaftor combination therapy resulted in improvement in multiple clinical endpoints, and the findings were generally consistent across those groups of studies. Clinically important reductions in the rate of pulmonary exacerbations were also observed in association with Lumacaftor-Ivacaftor therapy throughout 24 weeks. The Lumacaftor-Ivacaftor groups had reductions in the rate of pulmonary exacerbations with decreases in the number of events leading to hospitalization or intravenous in the number of events leading to hospitalization or intravenous antibiotic treatment.
Fibrosis is called FTCR gene. So, oh my gosh, it's a long acronym, and it stands for, let's read this quickly, Cystic Fibrosis. So they obviously named this after they named the disease. Cystic fibrosis transmembrane, which means it goes from one side of the membrane to the other. Conductance is letting things through across the membrane from one side to the other. And then regulator. So it controls the movement of something going across a membrane. The two ions that are affected are chloride and sodium. But keep in mind that CFTCR is a chloride channel. So chloride is physically being blocked by this channel not working. And sodium is affected because it has a relationship with chloride, but sodium has its own channel, which is not affected in cystic fibrosis. The CFTCR gene is all over the body, and depending on where it is, the situation is a little different. But the common rule is the same. And to illustrate this, let's talk about the sweat gland. This is a place where this gene has a big role. And from this example, it's kind of the same thing going across the body for cystic fibrosis symptoms. So if this is our sweat gland, it starts here. Sweat is secreted into here, it's a channel, and then here is the surface to our skin. I'm going to label this side skin. So when sweat is first secreted by this gland, there's a lot of sodium and chloride in it. For sodium, let's use blue. Notice that it has a plus charge. Sodium all over here. At the same time, there's also a lot of chloride in it. Chloride is a negative sign. As you can see in nature, positive and negative attract, right? So sodium and chloride like to balance each other out, and they're friends. In other words, the body likes the amount of sodium chloride to be about balanced. So going along this sweat gland going towards the skin, there's going to be channels to reabsorb this chloride and sodium into the body. We don't want to secrete it all out. So for sodium, we have its own channels. I'm going to use blue here. And they're just dotted along the way. Of course, next to them, there's the chloride channels. Now these channels are the ones that are affected by our CFTCR. Okay, I'm going to label this. So CFTCR. In cystic fibrosis, these channels are not working. But let's look at this as a normal one. So let's see, this is normal sweat gland. And normally, as the chloride flows down here, everything goes this way. As it floats down here, it'll leave through these channels and go back into the body. So this space here is the body, that's the skin, that's the outside. So these, as they go along, they go back into the body. And sodium does the same thing. Remember that we want to keep our amount of sodium and chloride pretty balanced. So as the chloride leaves, so does the sodium through their channels. And they kind of keep an eye on each other to make sure that their numbers are about balanced. So when we get to the end here, let's say that let's just say there are 2 sodium molecules left, and they're buddies, 2 chloride ions. Now sodium chloride, this is table salt. So this is why our sweat tastes slightly salty on our skin. And this is normal because not all the sodium chloride will be reabsorbed. Just as an aside, have you noticed that when you sweat a lot, it gets to be a little saltier, or the sweat has a stronger smell? That's because this is going through this channel faster when you're sweating a lot, and there's less time for these reabsorptions, so there's more salt left. But that's still normal. Here, let's look at a channel in a person with cystic fibrosis. So same channel. Structurally, everything's going to be the same. And here, I'm going to label this one CF. Now, initially, the sweat, the content of it being secreted into here is the same. So I'm going to use the little dots instead of writing it out this time. You already know blue is sodium and orange is chloride. So same channels for the sodium, and they're working just the same. There's no problem with sodium channels. However, this time, the CFTCR gene is not working, so the chloride channels are all messed up. So they look like this. It's not open. So as the chloride floats down this way, it can't leave. You see, it just has to stay in here and keeps going towards the skin. And sodium, at this point, it sees that the chloride is still in here. the negative and positive want to stay together. So even though the sodium channel is open, the sodium doesn't go either because its buddy chloride is still in here. And the body won't just take the positive sodium ions and leave the negative in here. It has to be balanced. So same thing, the sodium gets trapped in here too, pulled by the chloride. So in this person, when we get to the skin, it's almost the same content of sodium chloride as before. And as you can see, this is a lot more than just 2 of each. Now I chose 2 as an arbitrary number, but just to show you that this one is going to have a lot more. And this is a lot saltier on the skin. So one of the symptoms of having CF is having salty skin, or even a baby would do a chloride test to see how much chloride is on the skin, and they can point to CF. But the pathophysiology of this channel is similar throughout the body. I just chose one organ here to show you. Now really quickly, in the lungs, the problem is secreting chloride into across the epithelium to moisten the lungs. And since the chloride can't get secreted, the sodium also doesn't get secreted. And water follows sodium. That's why the secretions are really thick, because they're lacking in water. And that's how you get the thick secretions in the lungs and in the pancreas. But here in the skin, you get salty sweat.
Lumacaftor, Ivacaftor disadvantages. Lumacaftor and Ivacaftor can cause the following effects: pain or tightness in the chest, difficulty breathing, diarrhea, gas, excessive tiredness, heat rash, runny nose, sneezing, cold, sore throat, or flu-like symptoms, and sore throat.
Cystic fibrosis is a genetic disease that you're born with, and it affects your lungs and your digestive system. Every form of it is kind of different for everybody. Logistics are the same. Sticky mucus forms in your lungs, and it contracts your airways from breathing. So I take a lot of medication to make sure that I thin out my mucus to help me breathe better. I was diagnosed when I was 2, so I was a baby. But you're born with it, so the first 2 years of my life they didn't know what was wrong with me. On my 2nd birthday, my mom found out that I had cystic fibrosis, and she immediately started talking to people, other parents, got involved, and tried to figure out how the best way to handle this for the rest of my life. It is my life. For so long I didn't think it was. I lived a normal life. I played sports, I went to school, I had tons of friends, and I lived life like I didn't have cystic fibrosis. It wasn't until I was older when it really became real that I do have this.
Conclusion. In conclusion, Lumacaftor in combination with Ivacaftor improve FEV1 and reduce the rate of pulmonary exacerbations in patients with cystic fibrosis who were homozygous for the Phe508del CFTR mutation. Lumacaftor-Ivacaftor therapy generally had an acceptable side effect profile, with more than 93% of patients completing the assigned therapy regimen. This data showed that the combination of a CFTR corrector and potentiator designed to address the underlying cause of cystic fibrosis by targeting CFTR can benefit patients who are homozygous for the Phe508del CFTR mutation, and represents a treatment milestone for the 45% of patients with cystic fibrosis who are homozygous for this mutation. FEV1 and rates of pulmonary exacerbation are strong predictors of survival, and thus remain important for the evaluation of new therapy for cystic fibrosis.
This is a genetic disease that alters the body's respiratory, digestive, and reproductive systems. It affects the body's epithelial cells that comprise the lining of the lungs, pancreas, liver, sweat glands, digestive tract, and reproductive system. Normally, the epithelial cells release a slippery layer of mucus, captures dust and germs, and acts as a lubricant.